Hey everybody, it's Kevin and it's Thea in the Remote Care Services Show. Today I threw Thea a curveball in lots of different ways. She in fact went, "What are we talking about today?" But we're going to have a lot of fun in this episode because we're going to pull some different things together and kind of mesh MTM and some of the other services. So why you should stay tuned and watch after this quick clip is because right now medication therapy management oftentimes is kind of misunderstood in the pharmacy community because we have lots of different viewpoints on it. How we view it's going to be leveraged, the exact same thing happens with RPM, CCM in particular, chronic care management. And Thea and I are going to help you guys to kind of connect all those dots together and see why it could be beneficial for you. Talk to you in a sec. All right, Thea, we're back and we're able to kind of connect some things together. Thanks so much for being so nimble with me, like always.
Absolutely. No worries.
So off camera, Thea, to kind of introduce the topic, Thea and I were talking about this. An assumption of mine previously from being from a hospital clinical space, Thea also hospital clinical and retail kind of pharmacy space with knowledge was, lots of people know about MTM. But then me talking to individuals in the community, not necessarily the case because some of them said some of the barriers to entry, and there's a really good article put on US Pharmacists that I looked through before our talk. They was saying here are a lot of the things that are making it a massive barrier for folks to adopt MTM. Some of it was clinical workflow. Some of it was related to technology implementation. And a big one, a really big one, is billing. So them being able to get reimbursed for their services beyond what they would be investing into the service was massive. And one that Thea and I care about pretty deeply. We'll go into these a little bit further, but just wanted you guys to get an overview is being able to connect the dots with your patients, because a lot of times MTM is expecting you to be part of the clinical kind of atmosphere. And we know that unfortunately, we'd love to be able to make some differences here. And that's a big push for Thea and I at RPH Ally is trying to connect the community pharmacy and the health systems in general. But that's not always the case. And so now you have another barrier that the patients and the providers aren't looking at you as a member of the team in MTM always. And that can be a barrier. But Thea has some really cool slides. I want to pass it over to her to intro some of the other things that she's doing really cool in TM consulting. And I'll pull those up for us.
Yeah, just thanks for showing up today and being with us. Talking about MTM is something that I did prior to my life at the hospital and being a clinical pharmacist. I did it remotely when it first came out. So 2011, 12-ish, 10, 11, 12, I think I was doing it. And it was a great opportunity to really meet the patients where they were. I didn't know this kind of work existed prior to that because I had done retail floating, retail independent, and then some long-term care stuff. And I found an injury that caused me to not be able to stand for a while. And with that, I had to find a different alternative to doing work. And I found MTMs through a company online. I was on LinkedIn at that point, which surprises me. I've been on LinkedIn a long time then. And they looked at my profile. So I went looking to see who was looking at me. And here it was a job opportunity of doing MTMs remotely from home with pharmacists all across the country. So I got my feet wet in MTMs early. With MTMs, it really just is asking the questions of are the medications safe for the patient? Looking at what the patient has going on, looking at the medications they're on, and really exploring the opportunity of a deep dive on their medication regimen. A lot of it around quality metrics, around, adherence, around, if they have this disease state, are they on that drug? If they have, any interactions amongst the drugs, that's really what a deep dive into the comprehensive medication review really looks like from a retail setting, and that medication therapy management is what they like to call it. Lots of different names for it too. In a physician setting, it's called a comprehensive medication review, and they get paid for that. If you do it in the pharmacy, it's in a medication therapy management review, and you get paid for that through companies like Outcomes, which is now, I think, a Cardinal company. What that looks like, it really just lines out the 5 core elements that you see here. I did this these slides for a presentation at Pennsylvania Pharmacists Association, Con Ed, so had them kind of prepped for that. But with regards to the 5 core elements, it's really medication review, what the personal record looks like, medication record looks like, any action plans that are needed. Say they have high cholesterol and they're not on a statin, ask that they get that statin prescription, send that intervention into the doctor, as well as any referrals for the patient, and then document and follow up with the patient and then the provider. And Kevin talked about, what does this do? I mean, this is usually done annually. You can get paid for some secondary follow-up, but not usually as much. Really looking at about the $75 range, one time only. And you get notified when the patient is due for a medication therapy management through a lot of the different platforms that they have in retail pharmacy today. So really, not really up to you. You kind of get assigned if you sign up to do these kind of things. And, the revenue, I agree. Sometimes the revenue is not really worth it, but, how do I incorporate this into my day? How do I get the team members to help me? And it's not falling all on a pharmacist, and what that all looks like. I think medication therapy is going to be added to the workflow by a technician who is doing more around medication adherence, with your MedSync programs, and calling and outreaching the patient and seeing how they're doing, how their medications are there any changes, and really just align yourself up so you don't have to redo your adherence packaging first off, which is a cost savings, but also then to kind of fill in the gaps here, and what that could look like from a chronic care management standpoint as we move that way. So keep in mind what medication therapy management is, and then we'll take a look at what chronic care management looks like, because I feel like they're very, very similar, but what's not similar is the payment model, which is why pharmacists in independent world don't love this, because the return on investment isn't there. So let's take a look at the chronic care management realm of things as well. Really diving into the requirements of what care management looks like from an MTM standpoint. With care management, chronic care management, you have to have a relationship with the patient. You have to support the patient's disease states, right? You talk to them about their different disease states. They have to have access to you 24/7, whether it's via a message system or a phone, voicemail, that kind of stuff, as well as looking at the preventative care measures and encounters that they can have with regards to, preventing, like doing their screenings for breast cancer awareness, or with a mammogram, or screening around colorectal cancer and different things like that. Those are really your preventative encounters. And then education to the providers, and then prompt sharing of the care plan. So it's very similar to what an MTM is with regards to what you're actually doing. There's core elements that look very similar. And Kevin, could you go to the one that's MTMs versus CCMs? That one will show us what that looks like. Oh, it's kind of hard to see on here. Bummer. So on the left was of a screen there was what the outcomes platform looked like, and then what the chronic care management looked like together side by side, so that you could see them. But it really aligns that, yeah, there it is, that one. It really aligns so that what you're looking for is actually the same things that you've done with MTMs, if you're familiar with those, around patient demographics have to be listed, as well as tracking problems, asking what the barriers are for the patient. Sometimes barriers are never asked from a physician standpoint in that 7 minutes that they get with their provider on average a year. What the treatment goals are. A lot of folks have no idea what their treatment ideal goal is for the treatment. So we'll take example blood pressure. The goal for a person on blood pressure medicine is under 140/90, as close to 120/80 as you could possibly get them. So, the patients don't know that goal. They just know that they have high blood pressure and they take a medicine for it, but they have no idea what the goal is for themselves. So making sure that the goals are measured. I think that's a great place for, taking chronic care management and enhancing it to remote patient monitoring. I won't go there for this conversation, but definitely an overlap. And what they look like, though, from a MTM versus CCM platform is you're listing out the medications, you're listing out the barriers, you're listing out what we can do about it, and then you're offering resources on how to take care of it. And all of those things are the same. And so when you look at the difference between MTMs versus CCMs, the paperwork is highly the same, but the difference is that CCMs, once you collaborate with a doctor and have opportunity to really build the insurance for these opportunities, it goes from a revenue of $75 once a year to about $65 every month. And the person who sets the goals up for the patient doesn't have to be a pharmacist. Now, you can clinically talk to the patient when they come into the pharmacy because they're in there. You can clinically talk to the patient when the technician is calling out to the patient about medication adherence, just like MTMs. We were talking about that earlier. So really aligns with my thought around what you're doing to help the patients with medication adherence. These programs support that effort in my mind and really are lucrative on the back end as to what you do, because now you just spent 20 minutes with the patient doing med adherence to make sure that they need all of the medications in their adherence packaging, and you didn't get paid for it. But if you're doing chronic care management and have that collaboration set up with the doctor, and what that looks like really allows for you to capture that time. And when we look at some of the other barriers, to pull it back to that document we were talking about earlier, the barrier of, how do I get this information to the doctor? Or is it another platform? Is it, they're not linking with my other pharmacy software, and that's okay. It doesn't always have to, but where you have to have is ease of use for you. So maybe you do use a secondary platform for chronic care management or remote patient monitoring. That's okay, because it's going to track your time and it's going to give you the billing codes you need. And then you just send that right on over to the doctor's office and via a fax, because pharmacy is the only one in the world that still use a fax machine in healthcare. Or you can email it, and some are emails, but send it over to the physician, and you've just taken a program like MTM, which is only once a year, into a 12-month program for yourselves in that revenue on work you're already doing, because you're already calling the patients around medication packaging anyways. So, and talking to the patient when they come in or whatever, capture that time. And so it really aligns nicely with around medication adherence and quality that way. For how you would implement a program into the workflow of a traditional pharmacy, mostly independent pharmacy.
Boom.
Okay, Kevin, I talked a lot right there, and I'm like, okay, you got to talk a minute.
No need for that. But fantastic information. I think you just really laid out the entire foundation of why it makes so much sense to integrate into workflow something like CCM, because literally you're already doing it. And the other pieces you mentioned really with technology integration is the technology integration and the documentation necessary for billing is different than the necessity to be able to gather data and input it into your system. What is happening inside of CCM, a lot of the data that's being gathered and input into the system and updated is on the primary care provider side. So they're updating things on their documentation platform, so they're able to pull that into their records. Within MTM, a lot of times you have a portal or an individual system, and then you have your PMS, and you're having to transfer things back and forth. So there's not that level of, interaction that may be a little bit more frustrating with that overall platform. And then two, I think the one thing that I love to highlight, Thea, and it's just because I'm a relationship guy, is if you're working with a primary care provider, you have just united yourself with the entire healthcare system in your area. So now you are viewed as part of the team. And within MTM, as Thea points out in some of her slides there, it notifies you when a patient qualifies for a TIPS or a annual review, and it'll say when you're available. That has been the complaint with lots of folks saying, I can't get a hold of the patients. They won't answer my calls. They don't think I'm involved in their care in the MTM process. And then that adds on to how much money are you making per hour or per effort or per time. And so those pieces, I think, really add up to saying in chronic care management, you literally have to be introduced as part of the care team, and they're expecting to have this as part of their new regimen, for them to kind of go along the track to get better, to see advancements in their healthcare, to know that they can rely upon these individuals who will be helping them over this period of time. And so just those 2 points really wanted to push upon. I mean, we talked about the reimbursement piece, and I know that for colleagues of mine, reaching out to them, it was almost comical, them saying, Kevin, I would never waste my time with that because I'm not getting paid enough money. And me thinking about our conversations at the end, thinking, well, if they're not interested in that piece, they're already doing the workflow elements that you highlighted and pointing toward within CCM. they're developing the relationships, if we like it or not, with these doctors' offices by dropping off the donuts and getting to know them and having scripts come over. Why not take it one step further and really be able to help the patients in your community and get paid for the work you're already doing? So it, to me, it's a win-win kind of either way. But any other thoughts, I guess, Thea, because you've had really advanced experience in both worlds that you'd like to be able to pull away to let folks know, other than just do CCM? Like, it makes way too much sense. Let's get it going.
Yeah, I start now. That would be my first step. But the thing I think about is, a lot of times the fear of going to the collaboration, going to look for that service agreement with the provider and that kind of stuff. And I know we talked about that previously, but I really feel like if you went to Dr. Jones and said, Dr. Jones, I have 13 of your patients, and I have this program, and I'd love to start working with them a little bit more closely because I'm seeing that they're not taking their medications. That's a shoo-in. I don't care where you go or what endocrinologist or what primary care you can get a hold of. They all want to know how their patients are doing. They care. They don't have time, but they care. And so when you show up with some information that's actually attentive to them and their patients, with names, give them the names of these patients so that they see that you really are on the same team. I think that opens the door very, very quickly to having these opportunities to really get that going and get that service line going. And I will note that the MTMs are usually around an hour. CCM for that $65 is only around 20 minutes. And that 20 minutes doesn't have to be all by the pharmacist. It's coordination of care. So, you've just got your time down into a quarter or a third of it, and you've now made the same amount of money, and all of the work doesn't have to be you. So I think it's a no-brainer. As future of pharmacy gets more than dispensing, I think it is an opportunity to really grow and show what you need. So,
Oh, that's perfect. We had one question before we go, Thea, that I'd love to
yeah.
answer for Devin there. Do you need a CPA with each of the providers?
So it depends on the provider's placement, right? If they're in a group, you could probably get a group. I lean away from, and we've talked about this, Kevin, I lean away from collaborative practice agreements, CPAs, and lean more towards a service agreement. And that really comes down to trust. Providers, you cannot walk into a provider's office, much like they couldn't walk into you and demand their trust. And so when you line it out as a service that you're going to provide for them, like your cell phone service or like your platform service, whatever, it really aligns for a better opening to really over deliver. And then that collaborative practice where you're allowed to set those protocols and procedures in place that you're automatically making those changes comes with time. But trust is not something I walk in and say, I want your trust. I want to earn that trust. And maybe that's just my humble approach to it all. If you know the provider, it may work for you. I know in a health system, I could go to the health system physicians and ask for that. Because they've worked with me for the last 8 years. They know who I am and how I practice. So it would just depend, but I lean against that when starting and more towards a service agreement.
I love it. Yeah. I mean, just looking at some healthcare data this morning, Thea, really went from folks starting in even a hospital system of not having CPAs to now pharmacists being leveraged instead of CPAs for any kinds of dose adjustments, in general. And I see a very natural progression here too. When it comes to utilizing CPAs for each physician, like, as you mentioned, it usually is like, if you need a CPA for their patients and you need to make changes for their patients, the better idea is to get a CPA for each physician, even on a group documentation. So now you have the ability to, inside of Medicare guidelines, be able to connect the dots that the provider that is making the clinical decisions for those patients is part of that CPA. Otherwise, there's disqualifying elements. So that's the only other piece I had. But Thea, any closing remarks for us?
No, I think a lot of folks just need to get started on something more than dispensing against these PBMs. So, as always, I'm here to help mentor and grow any programs that are out there in the care management space, and really want the future of pharmacy to be wrapped around patient care and getting this health literacy up in the United States of America.
Boom. All right. Well, thanks so much, Thea. Always so much fun. You can find Thea and I over at RPH Ally on the Remote Care Services channel. And we will see you again here next week. You guys have a great day.